Okay, I'm recording. Good evening, everyone. This is Dr. Garais, MED120 for NAX. That's Monday evening, medical terminology, and today is Monday, August 24. What's due today are all topic 3, module 3 items, and that is, of course, your medical language lab assignments, your critical listening, exercises 1, 2, and 3, response exercises 1 and 2, and remember, the practice is just for practice. Quiz, of course, and the discussion forum as well. And please check your comments because everyone's doing quite well, but there's, just little formatting, some formatting issues that some of your future professors might take issue with and potentially remove points. Me, I'm not removing points. I'm always adding points because the more you fix, the more I add. And please, and if you get to me in a timely manner, if you're a later day or two for this class, especially if it's because most of our students, we have legitimate reasons why we didn't do what we needed to do. So please stay in constant contact. Always, always log in and always look for messages. I know I was supposed to give a practice exam over the weekend, but some of you may have experienced some Moodle issues. They were resolved this morning. I couldn't download anything over the weekend. I couldn't download anything this morning, but IT tells me that it should be okay today. So I'm gonna download after class an exam that I gave a while back, a midterm I gave a while back, so that you can have an idea how my midterm goes. And again, it's 50 items, multiple choice. You got to look at it like a big quiz, or like 4 quizzes just duct taped together. So if you look at module 4, week 4, that's where we're at. Next Monday is the midterm. If you already have reserved your spot for on campus, I will see you there at the 4th floor, 6 p.m. promptly. And for those of you who have already reserved your online, it'll be within, you log in, and at 6 p.m. A file will be sent directly to you via Moodle, not Moodle, via this Zoom thing. All right, and there'll be of course instructions and announcements in the days to come just to prepare you. Again, next Monday, week 5 is the midterm. Now, there'll be also instructions to ignore week 5 assignments or module 5 assignments because that'll be utilized for extra credit. Okay, so don't do any module 5 stuff. Do module 4 stuff because your week 5 grade should be your midterm. Okay, so week 4 stuff. What do we need? We're gonna do digestive, also GI system, and
yeah, I need to learn about this for sure.
Exercises 1, 2, and 3.
GI system.
Response exercises 1 and 2, and a quiz. And you know what? No discussion. Let me put that there. This will be a freebie so that you guys can have time to study. No discussion for. Study for your midterm for week. All right, so that'll be my gift to all of you. It'll be a freebie. Okay, and that's already posted. Okay.
Thank you.
Now, let us now go to the digestive system. And again, we always start with specialties. GE medicine or GI medicine, GE stands for gastroenterology. And if you break it out, gastro is stomach, enter, intestines, logi, study of. So that's the study of intestines and stomach. Also known as GI medicine, gastrointestinal, again, the study of stomach and intestines. Now, gastroenterologists are usually internists, such as myself, who do another 3 to 4 years, including another 2 years of fellowship, to be experts at your digestive system. And they're really good at interpreting and performing endoscopies. Now, if we look at the word scopy, remember the Y, that's a dead giveaway for process of. Process, scopy, process of viewing, endo, within. So when you look at the GI system, it's just one big tube that starts here at your mouth and ends here at your anus. And then there's a bunch of accessory organs. And the main purpose of the GI or GE system is to digest food. Remember that word? Let's look at this word. Oops, I have old notes. Don't save. Let's look at that word metabolism again, because that's what digestion really is. When you digest something, you're breaking it down. And that's what metabolism is. Meta means chain. Bol, ism. Ism is process of. Meta is the prefix that means change. Bol means growth. So process of change in order for you to grow. And what is metabolism changing really? You have food, and then it has to change the fuel. Essentially oxygen and the six carbon sugar, glucose. And that glucose, when you have your anatomy and physiology, or those of you who had already anatomy and physiology before, it makes ATP, which is adenosine triphosphate, which is metabolic fuel. This is the reason why we breathe. This is also the reason why we eat. We don't eat because it tastes good. It's just a nice little side effect. We eat actually for fuel. Problem with us here in America, land of plenty, we eat beyond what we require for the day's fuel. We're probably one of the few species on this planet that eats more than its share just because it tastes really good. Okay? And I am definitely one of those guilty. Now, you have your, just like your respiratory tract, you have your upper GI and your lower GI. Your upper GI and your lower GI, everything from the stomach on up, that's your upper GI, which includes your oral cavity and your food tube. Oh, of course, your throat, your pharynx, and your food tube here called your esophagus. Okay? So your trachea is your windpipe. Esophagus is the food tube. Okay? And the lower GI includes the stomach and all the small intestines and then the large intestine here. Okay? So when you do an upper GI series, which is either could be an ultrasound, it could be an endoscopy, it could also be an X-ray or a series of X-rays, and you hear the words upper GI series, that means where everything from the stomach on up. And the lower GI series is everything from the stomach on down. And if we're doing a lower GI endoscopy, I stick a tube right here in your anus, up your rectum, all the way in here, and it'll snake all the way up there. And if I want to do an upper GI series, I do it from here, either through your nose or through your mouth, all the way down here and into here. Okay, it is very unpleasant, and it's just like day surgery. We knock you out for it. It's a loads of fun, and you can always get a video of it nowadays emailed to you. It's pretty neat. So let's look at upper GI stuff. Let's look at the oral cavity. Oral, al, pertaining to your mouth. Dento, odonto, teeth. Now, dentist and orthodontist know the difference between the two, because ortho is the prefix that means straight. So an orthodontist, they deal with your teeth, but they deal with the shape of your teeth and the straightening of your teeth. Now, either way, if your teeth don't work, your GI system won't work, and all of us know that. All of us here have had toothaches. All of us here, or maybe the majority of us, also have had gingivitis, inflammation or infection of your gingiva, also known as your gum line. Now, that's really important now for cardiovascular medicine, because the bacteria that grows in gingivitis negatively affects the heart and predisposes the patient to cardiovascular disease. So you're overweight, diabetic, and have teeth problems and gum problems, you're asking for trouble. Lingual and glosso. By the way, doesn't this look like a beautiful both A and B question? This one too, the glosso and lingual. So you have a hypoglossal nerve. In your anatomy and physiology, where would you find the hypoglossal nerve? It would be underneath the tongue. Al pertaining to hypo means under or below. Hypo also means deficient. Remember when we talked about hypothyroidism or a hypodermic needle that goes underneath the skin. You also have other medication that we put specifically underneath your tongue, and that's your sublingual. And a classic example of that is nitroglycerin, because there, if you put something underneath your tongue, it certain chemicals like nitroglycerin bypass your liver, so it goes directly into your bloodstream a lot faster. And that's why if you have angina or chest pain, we give you sublingual nitroglycerin, and it stimulates nitrous oxide, which opens up your coronary vessels, and then it should alleviate your chest pain, in theory. But if your heart disease is progressing, it won't help you. Oral, mouth, of course, we went through that. Stoma, we already learned that last chapter. Stomatopathy, that's when I have a pathy. The Y gives it away. Disease process of my mouth. And again, you have problems with your mouth. It's like a conveyor belt. You're gonna have problems with digestion. You're gonna have problems with your gastrointestinal tract. So any stomatopathy, like cancer of your mouth or your throat, anywhere in that opening, that's not going to be good for the rest of your gastrointestinal system. Tylism is excessive salivation. Sialorrhea is also excessive salivation. So doesn't that look like a both A and B or an all of the above question? Hypersalivation, tylism, sialorrhea. You put that in your mental Rolodex as all of those things mean the same. Now let's look at the esophagus, which is the food tube, pharynx, which is your throat. Now, esophagoscopy or an esophagoscope, that's what we use. It's about 3 meters long, and we shove that down your food pipe. Well, don't shove, that's a harsh word, right? And that's going to do an upper GI series for endoscopy. And remember, the difference between scope and scopy, the Y gives it away. Scopy means the process. That is the thing that you'll be scheduling. Scope is the actual instrument. You know, how many times have I said that? I've said that at least 3 or 4 times. What are the odds of this kind of question will be on next week's midterm? I don't know. Pretty good. Pharyngeal tonsillitis. Itis, inflammation or infection of both my pharynx, which is my throat, and my tonsils. So that also looks like a beautiful both A and B question. Where is the inflammation in pharyngotonsillitis? Is it A, in my patient's pharynx, B, tonsils, both, or neither? Of course, the answer is C, both. Gastroscopy, stomach, right? Pylorus. Now, a pylorus is a sphincter. Let's look at the Stonematch. I always find English is my second language. I always find English very funny. We pronounce it stomach, but it looks Stonematch to me. Like Wednesday, Wednesday. Right? Let's look, we have a question. Everybody muted? I don't hear anything. Wait a minute. Maybe because all my stuff is low. So kindly unmute everybody. All right. Are we good? We can hear? Alrighty. So let's look at the stomach. And I'm still going to think Stonematch. That's just me. Okay. Let's look at this stomach. Now, your stomach, it's going to have like it's got a whole bunch of acid in it. I'm going to give a little bit of preview of your anatomy and physiology, or if you've had anatomy and physiology already. So the stomach, it's pretty much a multi-layered piece of muscle, and you got all these little folds. They're called rugae, and in order to keep all the contents in the stomach so it can be processed, so it won't leak out, and especially the acid. There's a whole bunch of pH 1 acid in here, hydrochloric acid. So you got to have these sphincters. Sphincters are circular muscles, and they act like a purse, like a coin purse. You know when you pull, why am I pretending, just talking about it? We live in a very visual world. Let's look at a sphincter so you can understand what's going on. So you can understand, look at what it looks like. So the sphincters, and one of the sphincters in your body, of course, is your anus. But yeah, let's look at your anus. You see here how it's all just a band of muscle that goes around in a circle, right? Just imagine like 3D, like in a circle here, right? Now, the only function of muscle is to get smaller. So it can tighten up like like a coin purse, like your sweats, and you pull on the string, and all of this can get tightened up, and it will close this off. Let's say if you have feces here and you want to hold it, of course your anal sphincter will close it off, and it's a circular band of muscle. Now, the same exact thing happens here. It goes at your cardiac sphincter, and here at your pyloric sphincter. And they call it the pyloric sphincter because this is the pylorus part of your stomach, and they call this the cardiac or the esophageal sphincter because this is around here is where your heart is. Now, when the sphincters don't work too well, the acid starts seeping out, and especially here, your esophagus or your food tube gets sensitive to that. And when all this acid starts kicking up here, right, it's going to cause pain. And that pain, right, we all know as heartburn. And when it gets out of hand, it's called GERD, G-E-R-D, or gastroesophageal reflux disease. Now we look at that. Reflux. Re means to go backwards. Flux means to flow. So it's backwards flow of acid in the wrong direction. And it's going to affect your stomach, gastro, and your esophagus, your food tube. So when we look at that, it starts kicking up here, right? If you have a GERD, right? You also get the GERD and stuff like that, like you eat way too salty foods or way too fatty foods or a really bad street taco. You can get really bad heartburn right here. Okay? And that they call it heartburn, not really because it's burning the heart. The heart is right here, but that's where it kind of presents itself, near the area of your sternum, which is near your heart. So that's that's esophagus, that's GERD, gastro, we put that all together. And now you know where your pylorus is. Your pylorus or your pyloric sphincter is the bottom end of your stomach that connects into your small intestine. And sometimes we got to cut that part, right? Usually for obstruction, or we could do it for cancer. We form a pylorotomy. Sorry, I'm trying to be fancy. Pylorotomy. Now remember our notes from week 1 and 2. Tomy is the process of cutting. Did we move the pyloric section of the stomach? No, we did not. We just cut it, right? And just to move the cancer or move an obstruction, right? Now, if I did a pylorectomy, then I removed that part of the stomach, okay? All right. Moving on. Suffixes, wash, rinse, and repeat. You've seen a lot of these. Gastralgia, gastrodynia, both pain. Beautiful, both A and B question. Vomiting is emesis. That kidney-shaped bowl that we have, the ones with the, the little markings on it. Supposed to vomit in that. This thing looks like a kidney dish. And let's show a plastic one, like this one. Does everyone see here on how there's like numbers here? Just a little clinical side note. Somebody vomits, make sure you catch the vomit in here. You not only write down in the chart how what was the consistency, color, was there blood, was there mucus, but you also have to note how much. And here are the markings here. And CC stands for cubic centimeter. CC or ml, they're both the same thing. ml is milliliters. ml is your metric system. So that's usually one of my pet peeves. I have nursing staff or other medical staff. Hey, Dr. Garais, your patient threw up. Okay, how much? When? How? And they're like, they just threw up. I just cleaned it up. But remember, we're clinicians. I need to know how much. And also the dietary medicine and the dietitians need to know how much as well. So that's emesis. That's your emesis bowl. Now, if you're having hyperemesis, or some of you ladies who are pregnant may had hyperemesis gravidarum. Structure gravid is pregnancy, hyper, too much, emesis, vomiting. So that is known as morning sickness. But ladies, it's morning, noon, and night sickness. So hyperemesis gravidarum, that's morning sickness. And if we break it down, my patient is vomiting hyper, too much, because they are gravid, they are pregnant. Because when you're pregnant, it takes all your hormones and shakes it up in a big bottle, and it's a train wreck at best. Because now all the hormones are geared for baby and not for mommy. And then that's why mommy has pica, and they like eating like dirt or odd things like their sweater. And maybe some of you ladies who have been pregnant can relate. I've seen a lot of it. I'm probably the only internist who's delivered 68 children. Successfully, I may add. Now, next, gastromegaly, cardiomegaly, right? Megaly, process of mega, of getting too big, enlargement of my stomach, abnormal enlargement. Cardiomegaly, abnormal enlargement of my heart. Hepatomegaly, abnormal enlargement of my liver. Splenomegaly, abnormal enlargement of my spleen. We can go on and on, right? Because we now know the parts, and you add megaly to it, now we know. Anorexia. Now, let's break down this word. Anorexia. And orex, ia. Ia we already know, state or condition. An is the prefix of no. Orex is eating. Now, what is anorexia really? It's the patient doesn't want to eat or doesn't feel like eating for a multitude of reasons. Now, you could have anorexia nervosa. Nervosa is like nervosis, right? Osa is abnormal condition of nerves. So my patient could have a mental disease or defect where for whatever reason they don't want to eat. And also in anorexia nervosa, they also have body dysmorphism syndrome. Dysmorphism. Ism, process of. This is abnormal. Morph is shape. People who have anorexia nervosa and people who really refuse to eat and to the point where they refuse to eat because they feel like they're gaining too much weight, or they look disgusting to themselves in the mirror. They have a little bit of this dysmorphism. That means they look at themselves and they find themselves ugly or disturbing, and no matter how much weight they lose, they always see themselves as too fat or too disturbing. Okay, so that's process of abnormal shape, dysmorphism, and give you a little bit insight on anorexia nervosa. And they can't help it because they look at themselves in the mirror, and then they get all bent out of shape. Dyspepsia, again, difficult digestion. You eat a bad street taco, what happens? If it has too much bacteria, especially E. coli, right? The person who made your taco didn't wash their hands too well after they went to the bathroom, you could get dyspepsia. Pepsia, EA, state or condition, PEPS, digestion, and this abnormal. Okay, so you could have epigastric discomfort or some pain, gastrodynia. You could have gas, right? And gas, another word for gas is flatus. Us means structure of gas, and that's in the GI. You know, when you have to pass gas or farting, that's called flatus, right? And that could be also a sign. You could also have borborygmus, structure of. The best way to say it is, you know those squirting and ugly stomach sounds you make, either if you've had something really bad to eat or you're really, really hungry. That's borborygmus. And that's why the doctor puts the stethoscope in your stomach. If you have GI problems or gastritis, I want to see if that comes out. We actually count it, how many times we hear the squirting action or those bubbling action per minute. Dysphagia, abnormal swallowing. You could have polyphagia, or you have abnormal, you eat too much, like diabetics, right? Diarrhea, let's look at diarrhea. Look at the way I use the word dia. I use the word dia complete or thorough. So let's look at the word dia. We already know rhea as excessive flow, right? Dia means complete or thorough. And that's actually what happens in diarrhea. Normally, we talked about metabolism, right? I take in oxygen, I take in water, and I take in nutrients. But what happens when you have diarrhea? When you have diarrhea, you're not taking any nutrients, you're not taking any water. So what happens? All of it goes to the toilet. So it's excessive flow, and none of the nutrients are going inside, and none of the water is going inside. So diarrhea, we have concerns over malnutrition and dehydration, especially in the very old and in the very young. Okay, and that's diarrhea. Now let's move on. Another beautiful picture and quiz. If ever you're in anatomy and physiology, which by the way, hint, hint, in anatomy and physiology, guess what I did? I copied this photo and went A, B, C, D, E, F, G. Too easy. And you could do the same at home. Sublingual gland, submandibular gland, your parotid gland. Your parotid gland is located in your cheek, but your sublingual, we already went through, underneath your tongue. Submandibular, underneath your mandible or your jawbone. So your parotid gland would be like somewhere here. Submandibular, because this is your mandible, that'd be here. And your parotid gland would be here. And those are the glands that help in salivation. And salivation is very important in the digestive process because it not only makes your food watery, it has enzymes in it to break down carbohydrates. And that enzyme is, anybody? Anybody know that enzyme? Well, that's for, what's it called that? That is for your anatomy physiology. If you know it, keep it to yourself. It's a nice 2 points on my anatomy physiology midterm. Oh, let's see. What are the good stuff? Oh, peptic ulcer disease, PUD. Now, what's an ulcer? An ulcer is a hole, right? Now, when we look at the stomach, The stomach is lined by a whole bunch of mucosa. And that mucus, if that starts to wear away, um, um, in your stomach, it'll create a hole like this one. In this particular area, there wasn't enough mucus to protect it. So what happened? The, the hydrochloric acid is pH 1. It's highly reactive and caustic to tissues if it's exposed. And it got exposed and then burns a hole in through here. This also happens in alcoholics because they have severe form of GERD. And if it gets really, really bad, they get esophageal cancer. And that's called the Barrett's esophagus, if ever you're interested. Esophagogastroduodenoscopy. Oh, that is called an upper GI endoscopy or an upper GI series. So what did we do? We stuck a tube down your esophagus, then went to the level of your stomach, right? And then stopped at your duodenum, which is the first part of your small intestine. So you have an esophagogastroduodenoscopy. Say that 10 times fast. Also known as a GI upper series or upper GI series. Ectomy, tome. Nice. This would be a nice question. A, B, C, wouldn't it? Which one is the actual process? Which one is the actual machine? Right? This is to remove. This is just to cut into. Let us see. Same thing. Oh, if I had a peptic ulcer, of course, what will I have? I might have some blood in there, right? So I might vomit blood. So if I vomit blood, I might have hematemesis. Emesis, vomiting, hemat, blood. Dyspepsia, we went over that as well. There you go. Now, let's now look at the lower GI or the lower gastrointestinal tract. Alrighty. Now, remember I told you right after the stomach comes your small intestine. Remember, it's just one big tube starting from your mouth all the way to your anus with the function of changing food into fuel. Now, the function of the small intestine is to absorb all nutrients, okay? Now, the three parts are your duodenum, jejunum, and your ileum. is the suffix at the end of all this, means structure of. So your duodenum is the first part, your jejunum is the second part, and your ileum is the third part. And entero is just the general term for intestines. Typically small intestines, because we have our own word for large intestines, which is colon. Now, duodenoscopy, jejunarrhaphy, ileostomy, you can make your own combinations here, and we already talked about those suffixes. Next, your appendix. Now, your appendix is part of your large intestine. It's this extra thing, extra tubing that sticks out. This is called a vestigial organ because it doesn't really serve any real purpose in your body. It's just there. But the problem is, if a piece of like peanut or foreign body or a fecalith, which is a really, really hard piece of feces, fecal meaning pertaining to the feces or poops. I'm going to write that down so you remember it. And a fecal lith. Lith means stone. Now, if you have extreme forms of dehydration, those of you who take care of our senior citizens for a living know that what happens. You get this all the time, and then you have impacted feces, and that's not fun because then you have to pull it out manually with your hands, and that's always never fun. So that appendix, we're not worried about really the appendix getting appendicitis. I'm worried about if the appendix gets inflamed and then bursts open, because if it bursts open, all the E. coli that's supposed to be inside your colon will now be floating around your abdominal cavity, which may lead to peritonitis. And the peritoneum is the covering of your, let me write this down instead of just saying it. Peritoneum is the covering of your abdominal cavity. Structure of surrounding and abdominal cavity. So if you can imagine it, if that colon breaks, all the feces get to float everywhere. And in feces, they have E. coli. Now, E. coli is supposed to be in your large intestine. It does wonders for your large intestine because it helps process vitamins. It does a whole bunch of things. But E. coli in my bloodstream or in my peritoneum will lead to peritonitis. That's bad news. Then leads to sepsis. That's even worse news. And then can my patient die? Yes. My last peritonitis to sepsis patient lasted about 3 hours. Okay, and upon what did we find upon autopsy? The only thing that was floating around in the blood was E. coli, and that was enough to kill him. E. coli belongs in your colon. It doesn't belong anywhere else. That means there's no such thing as good bacteria or bad bacteria, just bacteria in the wrong place and in the wrong amount. So E. coli in your colon, good stuff. E. coli in your sandwich, not so good. Proctologist. That's a person who's a specialist, right? They're usually a GI subspecialty, right? They're usually in GI medicine, and they're experts at the anus and rectum. And the rectum is the last part of your tube, and the anus is the sphincter part of the tube. And the sigmoid colon is the S-shaped S-shaped part of your large intestine. Let's look at that. All the things that I just said, because one thing saying it, it's another thing looking at your so you have your large intestine. It's called your large intestine because not because it's longer, it's because it has a greater and larger diameter than the small intestine. So here's the appendix, that little thing that's sticking out. And this is coming from your small intestine to your large intestine. You have ascending, you have a transverse, descending colon, then you have that S-shaped sigmoid colon, rectum, and then that band of muscle here, known as your anal sphincter or your anus. Okay, so anus is like the opening and the sphincter here. The rectum is the tube, and then the sigmoid goes a little bit higher. And you could see how we can do a lower GI series, right? I knock you out, right? And then, of course, 24 hours prior, I give you a detergent, something like Ducalax, and gets rid of all the feces in here. And then I can look at all of this via a lovely, lovely camera. Okay, so you could see there, I could have a sigmoidotomy, I could cut into it. I could have a sigmoidectomy. Rectocele, that's when the piece of the rectum, also known as the proctocele, it comes out. It comes out of your body because um, the muscles of your pelvic floor get loose, and people who get rectoceles usually women who had multiple pregnancies, and then they have vaginocele. The vaginal tube starts protruding outward, and a proctocele, which is your rectal tube, starts protruding outward. And that's not a good thing, because then if the inside is now on the outside, it's now open for infection. Okay. Okay, here's some Here's some examples of if we did some surgery here, right? We'd have to create a stoma, hence the term colostomy bag. Colo is your colon. So let's say, for example, my patient had cancer here. I don't want feces to ruin all my brand new stitches from all the surgery that I just did. So I anastomose this and this, meaning I cut all that out. I perform a sigmoidectomy and I take out that part, and then I form, I create a colostomy, which leads to a port to the outside world, and then a bag can be attached. And that's a colostomy. Very, very dirty business. We can put a man and a woman on the moon, but we can't make a colostomy bag that won't leak or explode. Pyloric stenosis. Stenosis, we already know what that is. Osis, abnormal condition of the tube getting slimmer or smaller. You can see here, that's the your pyloric sphincter, and now it's stenosed because it's all closed up, narrowed. Here's an example of lower GI series where we can identify the polyp, and within this tube, there's these little like alligator things that come out, and we could actually biopsy this polyp to see if it's truly a polyp or maybe there's an underlying cancer. We can also do some little surgeries here and there, like remove the polyp and then tie down the stem so it doesn't bleed out. Now, here is the concern of many oncology physicians. Oncology, of course, is logi, the study of onc tumors. Now, do you see this green pathway here that's related to the red pathway here, which is your arteries? Well, the way cancer spreads, it can also spread via your lymph ducts and your lymph vessels and your lymph nodes. Cancer can also spread through your arteries and veins as well. And stage 4 is the worst, because stage 4 is already metastasis when the cancer is actively traveling to other sites. Let me write that word down because that's an important word, metastasis. Metastasis. Meta, we already know is change. Stasis. Now, stasis is the condition of standing still. Meta is change. So it's what? Changing from standing still. I think that's right. And that's related to homeostasis. Homeostasis is, your body wanting to stay in the middle, wanting to stay balanced. So homeo means staying, standing still in the same spot. And that's what homeostasis is. For example, should your temperature fluctuate? No, it should be around 98.6. It should stand in the same spot. If you're just sitting around, should your heart rate and your blood pressure change significantly? No, it shouldn't. Okay, and that's homeostasis. Your body, all it does is want to be in constant balance, and that's what we do anyway. We don't cure anybody. What we do as clinicians is just simply manage their science, manage their healthcare, manage their homeostasis. So if you're too far to the left, I give you meds, I do some procedures, I monitor you, and I'm trying to put you a little bit towards the middle, and that's all we do. Now, this part is a little bit confusing, so I highly suggest study this more than once because I love things that, what's emoji reactions? No, I don't want any reactions. I love putting things that look and sound alike, and this cannot look and sound alike more than it can, and it's tricky. So one thing you have to know about, what is your gallbladder? Your gallbladder is, instead of me just talking about it, I really hate this. This should be down here forever. Let's look at gallbladder now. So what is your gallbladder? If you look at this, center it. if you look at your gallbladder is a storage, whoopsies, is where it stores bile. Now, bile is an emulsifier. It breaks down fats. So it makes common sense that it's it's along the route of your duodenum, which is the first part of your small intestine, coming from your stomach. Now, the gallbladder stores bile, and the liver makes bile, and then you have bile ducts, which are here, and you have your main common bile duct, which is here. So know that the gallbladder is an accessory organ to your gastrointestinal system. It helps break down fat. If you don't have a gallbladder, or if you had to remove it, you'd have to have a no-fat diet or a very low-fat diet forever, and you're probably going to be in Lipitor forever, right? But that's the function of the gallbladder. So let's look at some of these gallbladder words. So if I have a bile vessel, that's cholangio. And a cholangiole is a very small uh, end part of the tubing in your bile vessels that connect to your main bile duct. A cololith is a stone that could be stuck in any one of those um, um, uh, bile vessels or bile ducts, also known as a gallstone. Cholecysto is your gallbladder itself. Now, if I remove it, I just performed a cholecystectomy. And remember, ectomy, what do we do with our X's? We remove them. What do we do with this gallbladder? We removed it. Choletico means your bile duct. So if I had a cholecystectomy, what did I remove? I removed two things. I removed your bile duct and your gallbladder. So a cholecystectomy removed not only the bile duct, but the gallbladder as well. Hepato, we already know, that's your liver. Pancreato is already your pancreas. So hepatitis, of course, inflammation or infection of your liver. That's bad news. Pancreatitis, inflammation or infection of your pancreas. That's even worse news, or worser if you want to use bad English. Iasis, abnormal. So a cholelithiasis, what do I have? I have an abnormal condition of a gall or bile stone. Lith means stone, or calculus. Calculus, us, structure of, calculus. Something that's, this is how I remember that calculus means stone. If any of you ever taken calculus, it's hard, like a stone. Corny, but you should be able to remember it that way. Hepatomegaly, also not very good. Abnormal enlargement of the heart, that shouldn't be it. Now let's look at the word prandial, right? You can have pre and postprandial medication. So preprandial medication, it must be given before a meal. Postprandial medication must be given after a meal or following a meal, okay? Make sure that you patient knows the difference, because it causes great dyspepsia if you take meds at the wrong time. Further down, further down. Oh, here's another lovely picture of our gallbladder, of our liver, stomach, pancreas. Survey says, and more of the same. Come on, let's get to the nitty gritty. Next picture. Okay, here you go. Again, little disclaimer, Jaco doesn't like these things, but we live in the real world, so we have to look at these things. BE, barium enema. Sometimes we use that word. Now, what's a barium enema? Barium, when you look on an X-ray, makes your insides glow upon X-ray. So if I take a whole bunch of fluid and I put a tube in your rectum, and then I flood the rectum with barium, you're going to see a lovely picture. Let's look at this picture. See, Here it goes. You could see how it makes it glow in the dark more, and then you could see all the details a little bit better. Because if you look at something like this, you see you can't see any real details of your. But here, ooh, there's an obstruction right there. Okay, and it makes it glow in the dark better on X-rays. Another word for X-ray is radiograph. BM, bowel movement, of course, if you got to make a number 2. BMI, body mass index. CA, I like it for carcinoma or cancer, and not so much for these other ones. CT, diagnosis, we already went through. Esophagogastroduodenoscopy, we already went over. ESWL, extracorporeal shockwave lithotripsy. Now let's look at that 25-cent word. Extracorporeal, which means extra, out of, corpo, body, pertain to out of your body. Lithotripsy. Tripsy is the process of breaking down stones. Litho is a stone. So extracorporeal shockwave lithotripsy is I make you sit on a table, and there's a machine that shoots shock waves that come from out of your body into your body. And what will it do to those stones that we talked about, like your gallstones or your bile stones? It'll break them all up so you can pass them better. FBS, fasting blood sugar, also fast FBG, fasting blood glucose. We already went over gastroesophageal reflux disease, IBD and IBS, very, very debilitating disease and syndrome states, right? And if we look at the word syndrome, what does syndrome mean? Syndrome. Drome means to run together. Syn means same. So a syndrome is a whole bunch of signs and symptoms that all run together because they're part and parcel of the same disease, right? So IBS, right, includes IBD, irritable bowel disease. It also includes malabsorption syndromes. It also includes your diarrhea and also lower GI infections. All of that runs together. And same thing with AIDS, right? That's all in a syndrome that deals with acquired immune deficiency, right? So all of the things that run with AIDS, like Kaposi sarcoma and pneumocystis carinii pneumonia, low T4 count, which is your T cells, those all run together, and that's what a syndrome is. IV intravenous within the vein, so I can give you intravenous meds. LES, lower esophageal sphincter, yeah, semi-common. MRI, magnetic resonance imaging. OR, operating room. PUD, peptic ulcer disease. RGB, and not so popular. Roux-en-Y, gastric bypass. Now, what's a gastric bypass? Gastric, ick, pertaining to your stomach, and bypass. You want to create a connection that bypasses the stomach, so that let's say I did some surgery on my stomach. I don't want food to go through there. I want food and not to go by my stomach. So I form a Roux-en-Y gastric bypass, also known as an RGB. RUQ, LUQ, right upper quadrant, left upper quadrant. RLQ, right lower quadrant. LLQ, left lower quadrant of your abdomen. US also stands for ultrasound or ultrasonography. Oh, the rumbling or gurgling sounds, that's the correct spelling of borborygmus. Ascites is abnormal fluid accumulation. It starts in your peritoneal cavity, but it can go everywhere. And that's not a good situation. It means you have a fluid and or salt imbalance problem. And that's not good. And that could cause congestive heart failure, a whole bunch of bad things. Cirrhosis, or the hardening of your liver. Now, they call it hardening of your liver because when you look at it, it starts becoming yellow. Osis, abnormal condition. Your liver is full of fat. And when it gets damaged, parts of your body loves surrounding itself with fat because fat has glucose and has a lot of energy for the repair process to repair something that's damaged. The problem is if there's constant repairs being done, like in cirrhosis, it will start hardening up the liver, especially in chronic alcoholism, and then you'll have liver failure. Okay. Ascites fluid, we have to drain it, of course. Diverticulitis, celiac dysentery. These are things that are nice to know. But you'll go over there more in your pathology course or courses. Hematochezia, you know, hemat means blood. Chezia is stools. So it is a state or condition of blood in your stool, and that's not good. Now, hernia is an abnormal projection of the organ. Now, what does hernia really mean? A hernia, everything, all your intestines and all your organs are covered by a covering or some sort of sheath. Like your abdominal cavity is covered by your peritoneum. Now, if there becomes a tear or a defect in the peritoneum, pieces of this tubing will stick out. And if it sticks out, it causes pain and it causes a bump, right? And we call that bump a tumor. Because remember, tumors aren't cancer until we get the biopsy back. So you could have a hernia, and it could be here in your inguinal hernia, and that's why your doctor has to go feeling around here, right? Especially if you pull the muscle or strain yourself. Pancreatitis, peritonitis, we went over. Volvulus. Now, something that revolves, volvulus, is a volvulus. It's a twist. Now, a volvulus can also happen with like in a strangulated hernia. Like once the tubing is out of place, you know, just like your headphones or your old-fashioned telephone cord, right? If it starts twirling around in the wrong direction, it starts winding and then it starts cutting itself off, which is not a good thing. Now, I mentioned barium enema. We also could do a barium swallow. So I could make you drink and I could do the same thing. Endoscopy, upper GI series, lower GI series. We already went over that. Appendectomy, that's easy. And you can see it's much better to do an endoscopy versus me cutting you wide open. Cutting you open buys you another month of rehab and pain, but when you do an endoscopy or even ultrasound, it's just poking little holes in you. It's much easier. Lithotripsy, ESWL, we went over it. Let's look at some pharmacology. Let's look at some of these meds. Now, remember I told you that your stomach has a lot of acid, but if you have any disease states or your diet is really bad, or you drink a lot of coffee or drink a lot of alcohol, you're going to have a lot of acid in your stomach. And we could prescribe an antacid or something that's anti-acid, which is against acids. Of course, anti-diarrhea, we want to control the stools, right? Antiemetic, right? For those of you who have hyperemesis, ondansetron is really nice. We use it for chemo patients if they're vomiting too much. H2 blockers, and there's a H2 is the histamine receptor. You'll learn more about how that works and also how laxatives work in your pharmacology class. So you could see how your anatomy and physiology, your chemistry, math, all of it's going to come back. It's going to come around in the other classes. Now, next week, we're going to start looking at cases. So the cases are all located at the ends of these chapters, but we're gonna circle back around. Okay, that concludes the gastrointestinal show for today. Does anyone have any questions, comments, or recipes? If not, let me